69. If there are individuals standing who do not wish to stand, it's okay with me if you want to be in the room and stand, but and I did clear it with the fire marshal. So, all right. Welcome, everyone. Thank you for joining us for the Interim Joint Committee hearing on Health, Welfare, and Family Services. Today's October 26th, and I appreciate everyone indulging the earlier time. We will go ahead and call the meeting to order, and Secretary, please take the roll.
Senator Rocky Adams. Senator Byrd.
Present.
Senator Carroll.
Here.
Senator Givens. Senator Harper Angel. Senator Howe. Senator Kerr. Senator Meredith. Senator Nemeth.
Present.
Senator Wise.
Present.
Representative Bentley. Representative Bowling. Representative Bray. Representative Birch. Representative Dotson. Representative Elliott. Representative Fleming. Representative Fraser Gordon.
Here.
Representative Marzian. Representative Gibbons Prunty.
Here.
Representative Rayburn. Representative Raymond.
Here.
Representative Riley. Representative Sharp.
Present.
Representative Sheldon.
Here.
Representative Tate. Representative Weber. Here. Representative Westrom. Here. Representative Wilner.
Here.
Co-Chair Alvarado.
Here.
Co-Chair Mosier.
I'm here. All right, thank you. We will go ahead and approve the minutes from the September 28th meeting. Did everyone have a chance to read those? Any questions? I'll entertain a motion to approve. Second. All in favor?
Aye.
Any opposed? All right, the minutes are approved. I'm going to go ahead and consider the administrative regs that we have on our agenda today. I read through them, and they all look okay to me. Did everyone have a chance to read those, and are there any questions? All right. Okay, seeing no questions or concerns, I will consider those reviewed. First on our agenda, I'd like to invite Dr. Shanna Babylonis with the University of Kentucky to discuss sorry, a little sidebar discussion up here. Okay, we will hear an update on House Bill 604, which turned into a little bit different of a bill at the end of session, but did establish the UK Center for Cannabis Research. And we are delighted to have you this morning and look forward to hearing an update on how the implementation of the center is going. And what, if any, changes the veto made to the center. So I'm going to go ahead and let you proceed with your presentation, and we'll ask questions at the end. Thank you for being here.
Thank you so much for the invitation. So today I'll be presenting on the UK Cannabis Center and to provide some updates. So again, just to reorient everyone, House Bill 604 established the Cannabis Center at UK, and that provides us a $2 million appropriation, and we have 2 years to spend that money. So we have through June 2024. Dr. Capilouto appointed the director and the advisory boards. And I would just like to introduce everyone to the executive committee. So the executive committee is tasked with establishing the research priorities and the budget of the center. And I don't think that we could have a better collection of experts working with us on this effort. I think they're the dream team, and I'm so excited to have all of them here. But we have a wide range of experts across disciplines, and we have physicians, we have scientists, we have content experts, and then we have center directors and folks that have led very large research efforts in drug discovery and elsewhere. And so They comprise our executive committee, and then we also have an advisory committee, and they are tasked with advising the executive committee and providing feedback on the center progress. Again, experts in drug development, natural product science. We have the assistant dean for research of the College of Agriculture, 2 physicians, an oncologist, and an addiction medicine physician. And so we are really well-rounded. So I'd like to just present some of our initial progress. So we received a $2 million grant from the NIH for an inpatient trial to examine vaporized cannabis for opioid use disorder. We are also planning a cancer trial with the Marquis Cancer Center to look at edible cannabis doses for patients with cancer. And I would just like to highlight that this is going to be one of the first studies of its kind. You would think that cancer and cannabis have been really well researched. Unfortunately, that's not the case. And so this would represent one of the first placebo-controlled randomized trials for patients with cancer looking at plant-based cannabis in an edible form. So we're really so happy to be engaging in this effort. And my collaborator on this project is Dr. Zin Mint, and she's a fantastic oncologist, has done CBD research, and she's just a fantastic collaborator. We are also pairing with the Kentucky Injury Prevention and Research Center, or KIPRIC, to look at large data sets from the state. So we are going to be examining cannabis involvement in opioid overdose deaths, injuries, and driving fatalities. And we expect the first data sets to come in the spring. And part of this effort is to take a look at cannabis involvement in these outcomes, but also to provide a baseline for us. Should policy change, then we can really map that as a function of the time the policy changed and have a 5 or 6 year baseline established to be able to compare. We also completed a driving study. So we enrolled participants to participate in a cannabis driving simulator study where we compared various doses of inhaled cannabis to alcohol to look in a controlled setting how they were driving in the driving simulator. And we expect to have results here in the next few months. We also published 2 papers on a Kentucky CBD analysis. So we looked at CBD products sold in Kentucky and online and looked at the chemical constituents of those products to really determine how safe and how healthy and how accurate are these products. Kind of spoiler alert, there were a lot of label inaccuracies and a lot of THC contamination, which is really unfortunate. But we published those 2 papers in peer-reviewed journals. We are also tasked with applying for a cannabis growing license. And so we are planning a pilot growing project with the UK College of Agriculture with Drs. Ling Yuan and Jamie Matthews. And we have identified a growing area, an indoor growing area, and we have really multiple areas for rich collaboration there. So we're very excited. And then we're also exploring a collaboration with scientists in Pennsylvania to assess prescription opioid use in patients enrolled in the Pennsylvania Medical Cannabis Program. So what we would like to look at is the prescription drug monitoring program and the prescriptions that are prescribed to those patients before they entered the medical cannabis program to see what were they on, how often were they taking opioids and other drugs, and then really watch them in real time after they enter that medical cannabis program to see the real data. So not just a self-report of what medicines are you taking? Could you go down on your anxiety medicine? Could you go down on your opioids? This would be the real prescribing information. So this, again, would be the first study of its kind. And we are hoping to have data sometime between June and December. I would also just like to describe a little bit of the timeline for many of our clinical trials. So the cancer trial is here listed as an example. So we have study startup items on the left hand of the slide, And so UK has a lot of requirements, internal requirements to be able to start studies, especially in cancer patients. It's really rigorous review. So we anticipate approximately a 4-month review for UK and then a 2-month regulatory review for federal agencies. And then our enrollment in a preliminary laboratory study to look at safety and dose finding would probably take roughly 4 months. And then our outpatient trial would be 8 months. And so we anticipate having data finalized not until June 2024, just because that's just how long these studies take. And this is best case scenario. So this is actually lightning speed for a clinical trial. And I also just wanted to mention a few studies that we're exploring with the executive committee. So none of these have been finalized yet, but we're exploring these areas of lung inflammation to determine if edible, vaporized, and smoked cannabis change inflammatory biomarkers in the lungs. We are also considering an obesity study, even though we associate marijuana and cannabis with increased caloric intake afterwards, or the munchies. In fact, if you look at really broad scale data, epidemiological data, cannabis users on average have a much lower BMI than people that don't use cannabis. And so there's a lot of biochemical interest in why that is, but no controlled studies have ever been done. And so we're considering a controlled trial on this topic. And we're also very interested in controlled studies on pain. We also just recently launched a grant program at UK, so for pilot grants for faculty members. And the focus is going to be on controlled trials and public health impact. But we'll also consider grants on very few on basic and preclinical research, agricultural research, secondary analyses of large data sets, and community research. And we expect to have funding decisions made by the board in February and have the data available in May 2024. It'll give researchers approximately 14 months of solid research time. And that concludes my presentation if anyone has any questions.
Well, thank you so much. I am so happy to hear the results of your work. And you talked a little bit about lightning speed, and it sounds like you have just hit the ground running. So thank you for all your work. I think it's incredible that you have already secured a $2 million NIH grant.
Thank you.
Which was exactly what I thought would happen. You create this focused center for research, and the money will follow. And I think that's probably the first of many grants that we'll see. The work that you're doing is incredible. I could probably comment on every single piece of the research that you outlined, but I won't. I think it's incredible, and I just want to applaud your efforts. Are there any changes? Some of the language changed a little bit with the veto of certain provisions, but it doesn't sound like it's really changed structurally what you're able to do.
Not at all.
Okay.
Yeah, Representative, I'm Bart Harden, the Director of Government Relations for the
Thank
University
you.
of Kentucky.
Can you pull your microphone just a little
I'm
closer?
sorry.
No,
I'm Bart
that's-
Harden, the Director of Government Relations for the University of Kentucky. I think there were three basic components of the veto message that we had. I think the first one was, I believe the word research was taken out. But as you can see, we are an R1 research institution. That's what we do. That's what Shanna and her team are doing, is research. I think that had no material impact. The second piece that was vetoed was the makeup of the boards. That left that to the president of the university to determine. Again, I think you will see we have a very multidisciplinary approach to these two boards that have been constituted across campus. I think we've got basically the same individuals that were identified in the bill, plus or minus one here or there. So I don't think that had a material impact. And the third component was the veto of no funding beyond this biennium that was taken out. I mean, that's good for us. If the General Assembly decides they want to come back and put more money into this project, you won't have to notwithstand the legislation to do that. If you don't, we understand that as well. But those are the three basic components, and we don't think it really had a material impact on Shanna and her team's work.
Thank you. That's my observation as well. As far as the funding goes, I think that you are more than proving the importance of this center and of the state appropriation to funding this. So I just look forward to the great work that you're doing, and we do have a couple of questions. Senator Alvarado.
Thank you, Madam Chair, and Dr. Rabelins, thank you for the presentation. This is encouraging to see. This has always been my argument, I think, is that there's a lack of research on a lot of this topic, and the fact that you've stated that we have a lack of that, I think is important. I want to let the members of the press who are here, who always seem to report that there's all these studies and all this proof, I don't know that we have that proof, and so I'm encouraged to get the proof, either show it yes or no. One of the things I'm also encouraged by your comments is on a driving study, because I think there's been a lot of discussion about this, that people can be impaired, and clearly they can be, depending on the kind of THC content that you're either ingesting or inhaling. And if we can start even getting some kind of baseline on where that impairment begins or occurs, that can not only have impact for the state, it can have an impact nationally, really, for folks, just because right now we don't have any methods of testing for that. Law enforcement doesn't know if someone's under the influence, what that level is. The one thing I'm going to ask you, when you're doing these studies, and the one thing that I'm concerned with when you're using raw material, because I know that we've got medications that are derivatives of this, as there are for many things.
Yes.
Cocaine has medicinal purposes. LSD has medicinal purposes, but we don't use it in raw forms and say, here, take it, use it on your own. We extract compounds, we purify, we figure out dosages, safety, and then we go ahead and give it to folks. And we have that in things like Sativex and Epidiolex and Marinol. On something like this, where we're either using raw material or aerosolizing, are you controlling the amount of THC that's being given on these studies? And so I'm curious, is there varied levels, or is there a certain level that we're using for that basis for these studies?
So that's a fantastic question, and I appreciate that. So for our cancer trial, we don't want cancer patients to inhale anything. Like, that's just kind of antithetical to medicine, right? And so we will be using edible doses for those patients, and we'll try to really focus on an oral preparation for most of our studies for that reason. But yes, all of our plant material is very highly regulated. So the DEA and the FDA require that for us to be able to import or to obtain any cannabis material. It has to go through many, many layers of quality control. So we are selecting doses of THC, CBD, and their combination based on other literature, our own research, and other research to make sure that we have really safe doses that are that we think are reasonable and that may have some therapeutic value. But we are testing a variety of doses, and we'll make sure that everyone can tolerate those doses before we launch the study.
Okay, so you're using multiple arms with multiple.
Absolutely.
Okay, that's good to hear. I know we've looked at, and there's been varying studies on opiate use and being able to reduce that. I've often quoted one from Australia that was done in 2014. It was a 4-year prospective study. Did not find any benefit from reduction. And so I know there's others that are kind of suggesting there may be, but there can't be any inferences scientifically for that. So I'm encouraged. I mean, this has been the discussion. I think the medical community at large has been fairly resistant because we don't have the science. And if we're the state that's going to lead on this science, I'm encouraged by it. So we'll be looking forward to a lot of these results. And on the fact that you're doing a driving study, I think is a brilliant idea that really is going to be of benefit for a lot of folks too.
Thank you. And we're really excited about the opioid study as well. We really want to know, can cannabis help with opioid withdrawal? That's been a question that we've received quite a bit. And there's obviously lay press out there that suggests that that's the case, but there's been no controlled studies. We're also interested, does cannabis change opioid-induced respiratory depression? That hasn't been explored, and it's a really important question to look at health and safety. And then how does cannabis alter the rewarding effects, or like the high that is produced by opioids? And so that the study that I mentioned will address all those.
But these are all based off of raw material, correct? All of these studies, or are you extracting and using compounds?
We're not extracting at this point. And so we'll be using whole plant, but it will be in a ratio that we think it could potentially be beneficial.
And hopefully reproducible if we do that.
Absolutely.
In the future. Very good. Thank you so
Absolutely.
much. I appreciate it.
Thank you.
Representative Wilner, did you have a question?
Thank you, Chair Moser. I mainly just want to express my appreciation and enthusiasm for the center and for the project. And I just wanted to have clear in my mind, is this really the only center like this in the country, and is Kentucky really leading the way on this research?
So it's one of several in the country. So California has a huge cannabis research center, because I think they get roughly $200 million from their sales of medical marijuana in their state. But this is one of a kind in the country, and so I'd say that there's only a handful of other places that are able to do this. But what I would like to highlight is that UK is one of the only places in the world that can do an inpatient trial, placebo-controlled cannabis trial on an inpatient basis. So meaning that we admit people to the hospital and have them live there and can control their drug intake. There's probably 3 other centers in the world that can do that. And so this is really world class.
Thank you.
Yes, that is a very big deal. Representative Bentley.
Thank you, Chair Lady. We've supported this for many years. Glad to see some information coming back from it. During the crisis, it seems like the black internet went out and tried to find any THC that was more potent. So on your analysis, have you found any THCP? It's supposed to bind to CB1 30 times more than a regular THC molecule.
So there are so many unregulated products right now that are available for anyone to purchase online. You're absolutely correct. And so there's many derivatives of THC. So there's Delta 8, there's even Delta 9 for sale, HHC, Delta 10. There's many different formulations of THC right now that are available to purchase online. Anyone with a credit card can buy that, and it's all done under the guise of the Farm Bill mostly. We haven't analyzed any of those products yet. We only have analyzed the CBD-based products, and none of them had the compound that you mentioned, but plenty had Delta 9 THC.
Yeah. Well, I promote safety and efficacy. Thank you for your research. And
Thank you.
Thank you, Chair Lady.
Thank you. We have Representative Sheldon. Did you have a quick question?
Real quick. Yes, thank you. I was looking at the board, and yeah, you guys have done a great job putting together
Thank
some
you.
fantastic people here. I just kind of, at the end of the day, I have this real feeling that, you know, the DEA and the FDA are going to weigh in on your results, right? They're going to have comments to make. I just wondered, I would assume you're having communication all through these clinical trials with the DEA, the FDA, since you're having to get a lot of the substance from them and keep them informed. But I guess I wonder, would it have been any help to even have, because I know we're statewide, they're federal. Maybe there would be an argument that we'd keep them separate, but I may see some advantage to you, maybe including them somewhere in this group of professionals where they could, you know, because they're going to weigh in at the end of the day. I just thought maybe it'd be helpful. I don't know.
So do you mean in the board? So we were required to keep it just
Board advisor, whatever.
We were required to keep it with just UK faculty.
Right.
But all of our studies have to go through FDA and DEA review before we can launch them, and so they have a lot of input at the beginning on safety and like the legal ramifications of what we're doing. The DEA does, and make sure that we're doing everything in a proper way. After that, though, they don't really have much say, and so after they grant us the permission to conduct this study, unless there's something that goes wrong, we won't hear back from the FDA or the DEA along those lines, but we will report back to the FDA and our findings.
I really appreciate it. I just know they come up a lot when you start trying to pass, you know, legislation that deals with this, that, you know, they always seem to want to weigh in. I thought it'd be good to be ready for that. So thank you very much.
Absolutely. And I just want to mention that I met with the FDA commissioner, Dr. Califf, when he was on campus 2 weeks ago. And he was highly congratulatory of our work and just really couldn't wait for the cancer trial to be conducted. And so he was really encouraging.
That's fantastic. Knowing that you're one of the few across the country, I would have thought that. So thank you very much.
Thank you.
All right, this is very, very exciting. And Senator Carroll, do you have a question?
Yes, ma'am. Just quickly, and thank you all for being here, and thank you for the presentation. What part, or are there any parts of this research that will address the control as far as distribution? Should the state legalize, and then the importance of that? And I know the quality of the material and the ingredients in whatever substance is produced could be critical. Will that be a part of the study? Will there be any statement that comes out as a result of the studies?
So that wasn't one of the research focuses of the bill. So we tried to stick with what you all told us to do.
Okay.
But we are starting a growing program to determine if we can grow cannabis that matches the federal standard, that matches the international standard with the College of Agriculture. And we're exploring a collaboration with them to analyze that those materials as well. But as far as the distribution of cannabis, we're not looking into that.
Okay. All right. Thank you very much. Thank you, Madam Chair.
Thank you. All right, great discussion. I have one quick question to finish us out. Marijuana is still a Schedule I on a federal level. How helpful would it be to reschedule marijuana for research purposes?
It would be helpful. It would be helpful. So if marijuana became a Schedule II drug, researchers and physicians who already study Schedule II drugs could just automatically then start testing marijuana and using marijuana in their research studies. We have found ways to obviously get the work done, even though it is Schedule I, but it would facilitate research.
Okay, thank you.
Thank you.
That's very good to know. And I'm just excited that we were able to put this framework in place and really put UK and Kentucky at the forefront of research. It's critically important to study the safety and the efficacy of marijuana as a medicinal product. And I'm just excited about your work, and congratulations.
Thank you. Thank you all so much.
And I hope that you'll come to us if there is anything that we can do to help facilitate your work.
Absolutely.
Okay.
Thank you.
Thank you. Thanks for being here. All right, next we are going to hear about the importance of biomarker testing in healthcare. And I'd like to go ahead and invite Dr. Matt Holder to join the folks at the table to discuss both biomarkers and the pharmacogenomics piece of all of the testing that we're going to discuss. If everyone could, anyone who is here in person, make their way to the table, introduce yourself for the record. And I know that we have some folks joining us remotely as well.
Who's going to go first? Yep. You are.
Okay.
Well, good morning. I'm Tim Mullett. I'm a thoracic surgeon at the University of Kentucky.
Good morning. Thanks for having us. I'm Leah Phillips.
Will you turn your microphone on, please?
There we go. Hi, I'm Leah Phillips, and I'm a stage 4 lung cancer patient.
Hi, I'm Dr. Matthew Holder. I'm the founding director of the Lee Specialty Clinic, which focuses on people with intellectual and developmental disabilities in Louisville.
Hello, I'm Tony Remington. I'm the founder of Gravity Diagnostics.
Okay, thank you. And I think online we have Dr. Jill Colasar and Dr. Mike Gieske. Are you on with us? Oh,
sure.
I see you both. All right, perfect. Okay.
Good morning, I'm too.
Thank you. Thank you for being here. Good morning to you. Okay, so I think first we'd like to hear about why this is important. What is biomarker testing? What are pharmacogenetic testing? Give us kind of a little bit of background. Tell us why this is important, and then we'll go into the mechanism of actual testing. So thank you very much for being here. I know you are very busy, so I wanted to get you up here first, or near the beginning of this meeting. And please proceed.
Well, thank you very much. It's a privilege to be here, and I want to thank the committee for bringing this important piece forward. And I think Kentucky is known for a lot of things, but unfortunately, Kentucky is all too often known for our incredible burden regarding cancer. And this is not just a regional piece within Kentucky. It strikes across our entire state. I think we are known for being in the top 5, if not leading the country in these cancers, lung, colorectal, head and neck in particular, but also in melanoma. And then we have risk factors that are identified. Our tobacco use is heavy. Our obesity is an issue. We have environmental exposures such as radon, which is higher in many portions of the state, and then viral exposures that are continuing to cause increases in risk of many of these cancers. And then these are leading to health equity issues that are causing some disparities regarding geographic disparities in Appalachia, but also racial and ethnic disparities, and then access to screening and poverty continue to burden our population. This has recently been described very well in a document that is available at this website, either in an online version, in a dynamic fashion, or in a print version, in a 2021 Kentucky Cancer Needs Assessment put together by Dr. Pam Hull and the Community Impact Office at the University of Kentucky. It documents the burden of Kentucky's cancer problems, but also it will show you not only a comparative to the country, but also within the state in incidence and mortality, but also facts regarding cost of the cancers that we deal with. And then there are regional, for each of your constituents, there are regional distributions of how this is represented. So I want you to look at that. It's in the slides that we've provided. But the good news is the cancer mortality is diminishing. And certainly we've seen the faster decline in cancer mortality that's ever been reported in the country and in Kentucky. However, we continue to have a tremendous challenge. We've seen rates declining for a number of reasons, but we need to be more specific on how we are addressing these. One of the ways that we've done this, you all have helped us with dramatically, is recognizing the power of lung cancer screening and your influence in delivering the bill and passing the bill through your houses to be able to get this into law has brought us to a point where lung cancer screening has had the impact that we want it to. At least it's beginning to show the changes that we're striving for. Specifically, this has been promoted through our Kentucky Cancer Consortium, through the Health Care Collaborative, the influence of our research in the Kentucky Leads Project leading to modifications and adjustment to this law. And it's been recognized nationally. And so Kentucky is seen in the country as being recognized for driving lung cancer screening rates higher than certainly the national average. Data from 2021 reported this year. But looking at this in a different way to say that Kentucky is not only number 2 in the country in terms of hitting the eligible population, almost 3 times the national average, but for the state that has the highest burden, we have one of the highest highest screening rates. And so this is a starting place that we have to be able to drive forward. Now that's recognizing early stage lung cancer. One of the challenges is that late-stage lung cancer is present in 80% of the cancers that are identified. And so now the good news about that is that in the last several years, we've seen that rate decline. And that's a huge change because if you have 80% of your diagnosed population with lung cancer having a mortality of 4 to 10, or survival of 4 to 10% over 5 years, and you move that group of patients into a area that has a survival of 70 to 80%, we are going to see a shift in our lung cancer survival from where it is now, 15% or so on average, to probably better than 30, 34% over the next 5 to 10 years. And so if we continue this trend, so your lung screening efforts are huge. However, we still have 7 out of 10 patients with lung cancer diagnosed with late-stage diagnosis. 100 years ago, we looked at this, and surgery was the only way that we had to treat this. And so we initiated a practice across the country now that I am the chair of. That's the Commission on Cancer, and we are represented in Kentucky with one of the highest populations of centers that are identified in the Commission on Cancer, over 40 centers in Kentucky. And the importance of this is that we exist to drive existing knowledge into practice, and that's what we really want to talk about today, is driving biomarker testing into the practice. It needs to be recognized that cancer is a genetic disease. This is not something that we can cut out of patients if it's a widespread disease. It's certainly an opportunity for us to understand how it gets started, though. We certainly recognize that changes in the genes that control the way cells grow lead to the tumors that we find, and these genetic mutations are being discovered more and more frequently. These genetic changes occur because of damage to our DNA. It happens all the time. We have many mechanisms to repair that damage, but sometimes it gets away from us. And that is aggravated by tobacco, ultraviolet sun, by radon, by other factors. And these are the genetic causes of damage that we are dealing with. UV radiation, radon radiation, smoking issues, viral issues, all causing sequential damage to the DNA that we have. The great news about this is that we are identifying targets in these mutations and then drugs and clinical trials to be able to evaluate these mechanisms of treatment. Back in 2012, half of the lung cancers in this case had no recognizable mutation. In 2015, that number was diminishing, and then 2020, that number is down to about 10% and continues to become smaller. The importance of this is that all of these other acronyms and identified mutations are beginning to develop drug targets that can be specifically addressed. And I will say that I'm here because 10 years ago I had a stage 4 mutated tumor, and I've been on one drug for a day, every day, and that's the only reason that's gone. So this is a powerful mechanism, and these biomarkers are being recognized by the national guidelines that are promoted. The challenge is that we have problems getting them into practice. Those barriers include lack of awareness, the complicated nature of being able to get the testing done, the mechanisms to be able to drive this into the practice and change the mechanism that our providers are delivering care. And so I think this is where this policy change can be able to deliver decreases in barriers, decreases in those obstructions that exist to be able to get this into the practice of the cancer providers that we have. I think it's important that we're talking specifically about drugs that address the diagnosed cancers and trying to get them using the recommendations that are out there from the knowledge that we have from the clinical trials. So this is a key piece of information, and I'm excited to be able to see you take this up. Thank you.
Thank you. Dr. Kolasar, I'm not sure exactly what order, but we have you next on the agenda if you'd like to proceed.
That sounds great. Would it be okay if I shared my screen?
Yes, please do.
Oh, I think somebody needs to, oh, very good. Okay. All right, can you see my screen?
We can, yes, thank you.
And can you hear me okay?
Yes, if you could just introduce yourself for the record.
Sure. Thank you very much for having me today. I'm Jill Kolasar. I'm a professor at the University of Kentucky and a clinical pharmacologist. I apologize for not being able to join you in person. And what I'd like to do is give you a brief overview on biomarker testing and some of the work that we've done at the University of Kentucky. So there are basically two places to test for biomarkers, either in your somatic germline or in your hereditary germline. And I put this chart together to give you an idea of the differences. And so I think one of the most important things in terms of somatic mutations, they only occur in some cells, and we think about this most often in cancer. Another really important thing to think about with somatic mutations is that they're not passed on to your children. The diseases that are primarily associated are going to be cancers. 90% of cancers are caused by somatic mutations. As you saw in Dr. Mullet's presentation, we're exposed to radon, we're exposed to sunshine, we're exposed to cigarette smoke, causing those genetic mutations in specific organs, which results in the cancer. But again, that cancer stays there. When we compare that to germline testing, germline mutations, those you inherit from your parents, those are passed to your children, and they're present in all of the cells. About 10% of cancer is caused by germline mutations, but there are a variety of other different diseases that are caused in this manner. Inborn errors of metabolism are one of them, hereditary cardiac defects, malignant hyperthermia. And another important thing, and what we'll hear about in one of our subsequent speakers, is these also control drug metabolism. So depending on what type of mutation or biomarker you're looking for, it depends on how you need to test. So if you are looking for somatic mutations, you're going to do a tumor tissue with a biopsy. There is an emerging presence of liquid biopsies, and what those do is they actually detect cancer DNA that's been shed from the cancers. So that can be an option for patients who are not able to undergo a tissue biopsy. In the germline setting, you can use a buccal sample or a blood sample. Well, basically, you could use any type of tissue that is available. But these are certainly going to be the easier things to obtain. In terms of use of these biomarkers, and for somatic biomarkers, we use them to diagnose cancers, and we also use them to select treatment. In terms of germline, in some circumstances, we can select specific treatments for our patients. We do it to identify hereditary cancers or other diseases that before they manifest, and to induce some prevention efforts. And in terms of drug metabolism, what we're really doing is trying to optimize the dose and prevent adverse effects. In terms of cost, somatic mutation testing is a panel test. Generally, it's about $2,500. And in terms of germline testing, it varies by the test depending on how many different mutations you're trying to identify. So I'm going to focus my presentation on somatic or tumor-only mutations, and this is in the context of lung cancer. So what we really are able to do now, it's one of the major advances in cancer treatment, is to identify patients at the molecular level. We can take a piece of their tissue or a blood sample, look at the mutations that are present in their specific cancer, and based on those cancers, we may be able to identify a new drug that targets that specific mutation. So, and if you look at the pie chart on the left, we have so many different targets now, and so this is really something that has changed over the last 20 years. I always like to show this slide. So if you're not used to looking at survival curves, basically on the y-axis is going to be percent survival, and the x-axis is always going to be time. And so the study that I'm showing you on the left is a very famous study that was done by the Eastern Cooperative Oncology Group by one of my good friends, Dr. Joan Schiller. And the premise of this study that was published in 2002 is really, we have 4 chemotherapy regimens that are commonly used for treating lung cancer. Is any one of them better? And what you can see by looking at these graphs is that, no, all 4 of these lines are basically on top of each other. And this is in months. So by 36 months, survival outcomes are very, very poor. And the median survival in 2002 was actually 8 months. I'd like to suggest that we have made major advances in lung cancer treatment. Looking at the curve on the right, this is survival in 2022. The median survival for lung cancer today is 4 years. That's 4 times more than it was 20 years ago. And most of the credit for that is given to new drugs, new therapies, and in particular, these targeted therapies. This is just to show you how many new drugs that we have for treating lung cancer. I haven't counted them up lately, but there's more than 20 different drugs that are potentially available to patients with different mutations. The other thing that we're learning as we continue to follow patients and they live longer and longer, a lot of times someone with an EGFR mutation will progress, but they'll go on to get an ALK mutation. And so then we have more drugs that are backups for them. So I hope I convinced you that biomarker testing is very important, because to be able to identify those mutations and improve overall survival for our patients, you need to do the test. So this is a study that we did looking at testing in Kentucky between 2010, 2011, and 2012. And this was just single gene testing for EGFR, which was standard of care at the time. So this would have been recommended for all patients in 2010 and 2011. And when we look at the EGFR testing rates, they're extremely low, 6%, 10%. And in modern times, as recently as 2021, depending on where you live, the testing rates for biomarkers are really only about 50% in the best case scenario in academic medical centers, and range down to about 40% in rural areas. So still, I think we have a long way in going into implementing biomarker testing as part of routine clinical practice, which is recommended by clinical practice guidelines. So one of the approaches we took at the Markey Cancer Center was to work with community medical oncologists, because they had the lowest testing rates, in order to improve testing. And so one of the concerns in community medical oncology practices is that they don't have time to do the testing, they don't have, and they don't know how to interpret the report. So the Markey Cancer Center set up a molecular tumor board. Our molecular tumor board is an interprofessional team, including a number of surgeons, physicians from different specialties, pharmacists, and genetic counselors. And the purpose of this molecular tumor board is to review these next generation sequencing reports that can come back, and be 20 pages long and have 50 different mutations, and make recommendations to the treating medical oncologist as to what might be the best treatment option for that patient. So I'm showing you here on the right in Kentucky, the gold stars are community medical oncology practices who are participating in our molecular tumor board. And I show you the numbers down below. We started in 2016, but in our defense, it was December. So we only reviewed 2 cases in 2016. Got up to about 200 between 2017 and 2018, and have had continuous growth other than this little blip for COVID. And in 2021, we reviewed more than 700 cases, and 77 of those were coming from community medical oncology practices. So the next thing we wanted to do is we wanted to determine if we were having any positive impact for our patients by encouraging this testing and by helping interpret these reports. So the next thing we did is a case control study. And so we knew the patients that were reviewed by the molecular tumor board, and we selected cases from our Kentucky Cancer Registry. And to be a case for one of our controls, they were matched on age, year of diagnosis, gender, where they lived, insurance, and smoking status. And that was just to control for factors that could predict outcome. In addition, we also controlled for survival. So sometimes patients with rapidly progressive disease do not get next generation sequencing testing. So to be included as a case, you had to survive at least as long as the controls. And these are our outcomes. Again, this is going to be a survival curve. So survival up here in panel A, 101 is 100% survival. And then this is time, and this is in months. So, and I think what you can see is there's a very large separation in the curves. Patients who were reviewed by the molecular tumor board, almost all of those patients were still alive 4 years later. And comparing that to the patients who did not have the molecular tumor board review, it's more about 40%. So in other words, patients who were reviewed by the molecular tumor board and were matched on survival at study entry and all kinds of factors that could predict outcome, including presence of a mutation, lived about 8 times longer. So we were very encouraged by this data, and to continue with our efforts with our molecular tumor board and to continue our efforts for biomarker testing. The other thing that we wanted to look at was, did your place of residence matter? So if you look at panel B, there were 26 of the patients reviewed by the molecular tumor board, 26 were from the community, 51 from Markey Cancer Center. And you can see up here that there's really no difference in survival. And in panel C, we demonstrate the same thing. It didn't matter if you lived in Appalachia, if you received a biomarker test and were reviewed by the molecular tumor board, you had improved survival. So thank you very much for the opportunity to talk about this today. And maybe we're saving questions for the end, but I'll be happy to take questions when the time is right.
Okay, thank you so much. Yeah, I think we'll save the questions till the end. I know that Dr. Gieske is here to give us a brief overview, I guess, on continued use of biomarkers, and then we'll go to Dr. Holder.
Thank you. Appreciate that. Thank you for this opportunity. I'm Mike Gieske. I'm the Director of Lung Cancer Screening from St. Elizabeth Healthcare, family practice doc. I've been in practice for 35 years. And I look at things pretty simply. You know, I think it's important that we understand the terminology when we hear the term biomarkers. There's biomarkers that can predict your risk of cancer or cancer predilection. There's biomarkers that can detect cancer, and it determines the presence of disease. And then what we're primarily talking about today is cancer direction or treatment. These can be liquid biopsies or tissue biopsies that guide your treatment. With respect to prediction biomarkers, we're working with an R01 study with the World Health Organization, looking at a 36-panel protein that predict your risk for lung cancer. And this can be combined with screening to improve the accuracy and the breadth of screening. There's a term called MCED, multi-cancer early detection test. We now have tests, of course, screening tests that can reduce mortality for 6 cancers: cervical, lung, breast, colorectal, and prostate. These MCEDs can detect over 50 cancers. And the question is whether or not detecting these cancers will decrease mortality. And it's going to depend on getting a lot of regional, national, and international data. But these MCEDs detect incredibly infinitesimal amounts of circulating DNA, RNA, or proteins. And the public is now aware of these tests. They can increase screening rates as well, and they are here. This is looking at a pictorial representation. This is a tumor cell over here on the left. It sheds pieces of DNA, RNA, proteins, and tumor cells into the blood that can be detected. And then once these pieces of DNA or RNA are found, machine learning and artificial intelligence can determine from the fingerprints of the methylated cell-free DNA and RNA fragments where those tumor cells came from. But these tests are expensive. These are not yet covered by insurance. They're not FDA approved. And, the question is, will these tests further increase healthcare disparities? Because they are expensive, as we've mentioned. Tim showed this slide already. I won't go over this again, but these are the targeted therapies we're talking about. There's now 9 genes with driver mutations. These are the mutations in the drugs that we use. And these drugs have made a tremendous difference. We now have cancer patients, lung cancer patients, that are here with us 5, 10, 15, 20 years later because of these drugs. And they're finding new ones almost on a weekly basis. Immunotherapy is another frontier. And this is based on PD-L1. You have a much better chance of responding to immunotherapy. These are some of the drugs I'm sure you've heard about on TV: Opdivo, Keytruda, Tecentriq, Imfinzi, and Yervoy. This is a picture of Heidi Nathman-Onda. She's a spokeswoman for the White Ribbon Project. And this just gives you an idea of what we're looking at here. This was 4 years ago, and this is a tumor in her left upper lung. Now, 4 years later, she just had this scan 3 weeks ago. And there's been no evidence of disease for several years now. So 4 years later, hopefully she'll be among the survivors from the treatment of immunotherapy. And as Jill mentioned, I think, and Tim did as well, these tumors, they develop resistance. They continue to evolve. They outsmart the treatment. So these biomarkers have to be periodically retested, and we will develop some of the therapies based on that evolution. And it'll probably take combinations of therapies. I won't go into all the details of this in the interest of time, but when we add biomarkers to traditional testing, it increases the sensitivity and the specificity. And we definitely need better prediction models, and biomarkers will be part of that. Tim mentioned radon, and a lot of the rest of the world, cooking oils and open wood burning are factors. We know family history is a factor. Air pollution is a big factor. Just to give you an example, in Taiwan, 53% of lung cancers occur in individuals with no smoking history. So there's lots of other factors in play here, and biomarkers will help us sort that out. So cancer care is entering an extraordinary era, and lung cancer has been increasingly at the forefront of many of these emerging technologies and treatment. And we cannot tolerate progress for some, but not for others. And that's part of why we're here talking with you all today. Achieving equitable cancer care and outcomes is going to be increasingly difficult. Thank you.
Thank you, Dr. Gieske. So we've talked a lot about cancer, and now I kind of want to move into the use of pharmacogenetic testing in other applications, because there are other applications, and Dr. Holder has some experience in that area. So welcome, and tell us a little bit about how you see pharmacogenetics playing into other treatments.
All right. Thank you so much. Honorable members of the committee, thank you for allowing me to give my comments today. My name is Dr. Matthew Holder. I'm the founding director of the Lee Specialty Clinic, which is in Louisville, Kentucky. It is a clinic that provides interdisciplinary, integrated whole person care for adults with intellectual and developmental disabilities and transitioning youth. We see some of the most medically and behaviorally complex patients in the state. And I will say proudly that we are a national leader in the model of care that we provide, and we owe that to the Commonwealth of Kentucky and the legislators who support us. So thank you very much for that. In order to understand the role of pharmacogenetic testing, I need to tell you a little bit about people with intellectual and developmental disabilities. The group of people that we take care of, you'll know some of the diagnoses that we see: autism, Down syndrome, cerebral palsy. Those are the more common. However, the range of diagnoses that we see span probably 1,000 different rare and very rare and super rare different disorders. There are certain common characteristics that occur with this population. So intellectual disability is one, difficulty communication is another, behavioral and psychiatric disorders is another, and there are many others. One of the very common things that occurs in this population, and you can imagine if you were somebody with an intellectual disability, you had something difficult happening in your life, and you didn't quite understand it, and you didn't have the ability to communicate it. One thing that would probably happen is you might turn to a behavior to let people know how unhappy you were about it. Unfortunately, when this happens, it often gets misinterpreted as a psychiatric illness of some kind. And I've seen in my medical colleagues, and national surveys bear this out, that that when patients with IDD, intellectual and developmental disabilities, when patients with IDD go to the hospital, that they are diagnosed with psychosis 11% of the time. Now, I can tell you that 11% of our patients at the Lee Specialty Clinic are in no way psychotic. However, there are lots of antipsychotics being prescribed to this population. This is through something that we call diagnostic overshadowing. So there's a lot of medications that are being prescribed here. When we see at our clinic, we see patients who first come in. Our average patient is on 13 different medications. Lots of those are behavioral drugs. At our clinic, after they've been there for a while, our average patient's on 11, and by the time they graduate out from being a patient, then they're probably on about 9 different medications. One of the primary things that we try to do is to get people off of medications. And one of the big reasons why those medications are prescribed so much is because physicians don't really know much about this population. The training in medical schools is pretty light. And like I said, it's a fairly rare population. However, despite the fact that it is a relatively small part of our population, it accounts nationally for about 16% of the Medicaid budget. So it's very expensive. And the reason why has to do with the fact that when physicians start treating this population, they don't know where to start. So we do what physicians do a lot, which is prescribe lots of medications, and we do that very well. And we don't really get people off of them very well. So that's sort of a little background about the population. Now, let me turn to pharmacogenetic testing and how we utilize it in working with the population. So I think everybody here actually has experience with pharmacogenetics, and I'll use caffeine as an example because probably everybody here has taken that drug today. But we all sort of have an idea of what this is. Most people can drink a cup or two of coffee and it works out okay. I'm a lightweight. If I drink a half a cup of coffee in a day, I'm going to be up till 3 o'clock in the morning. There are other people that you know who can drink 3 pots of coffee and they'll be able to go to sleep the next hour like nothing ever happened, Senator Alvarado. So there is a wide variety in that particular substance of how people process that particular drug. And that has to do with not really tolerance necessarily to caffeine, but how the genetics affect the way that you metabolize something. Now imagine if I were talking instead of caffeine, I'm talking about a very heavy duty drug like an antipsychotic, which as I just said gets heavily prescribed in our population. If I am prescribing that to somebody and they are a lightweight, then I run the risk of oversedating that person. And if I oversedate that person, now we're running the risk of an emergency room visit, of aspiration pneumonia, of all kinds of adverse outcomes that could potentially occur because I oversedated that person. The counter to that is if I start prescribing that drug and I don't see an effect, what most physicians will do is just keep upping that dose more and more and more and more until we finally see an effect. However, just because we're not seeing a primary effect doesn't mean that the side effects aren't compounding every time we increase that dose. And so with antipsychotics, what happens over time, it is a very rough drug over time. You end up with movement disorders and again predisposing people to swallowing problems, aspiration, and that leads to ventilation events in hospitals and things like that are extraordinarily expensive. So on either end of this situation with antipsychotics, there is a very expensive outcome. Now, sometimes you do have to prescribe those drugs. That's just the reality of it. So when we prescribe those things, especially in a patient who can't really tell us whether the effect that we're giving or we're looking for is actually happening or not, we have to rely on sort of a gut check. We have to know where to start, and we don't know. One of the very, very useful tools here is pharmacogenetic testing. Pharmacogenetic testing allows us to get a profile of the patient and look at the way that they metabolize different types of drugs and gives us an indication as to whether that drug is going to be effective, a higher dose is needed, a lower dose is needed, or maybe it's not, maybe it's very ineffective. So that gives us a place to start, and it helps us to avoid those sort of bookend expensive problems that happen when you don't know. The other thing is, as I mentioned, we have a lot of patients who are on lots of drugs, and we try to get people off of those drugs. When you're sitting there with a patient who's on 13 different behavioral medications, it's kind of hard to figure out where you're supposed to start to get somebody off of that. It's a very long process, and we have ways of doing it, but it's difficult. One of the really nice tools, again, is pharmacogenetic testing, because many times we can look at a particular drug and we can see the profile and say, oh, it looks like that drug probably isn't even working. Why don't we start with that one? And so we can start systematically weaning people off. Again, this is going to save us a lot of time and a lot of heartache. So really what it comes down to, in my view, this is, I think, the future of medicine. This helps us individualize our care. It helps us tailor our care to people. Genetics don't change that often, so you do this test pretty much one time, and we have a pretty good idea of what we need to do from that point in the future. But what this ultimately does for our patients is it improves the quality of their health. It reduces the amount of misstarts that we have as physicians. And it helps doing that while decreasing costs at the same time. It more than pays for itself. And so that's my comments. Thank you very much.
Thank you so much. And I hope that this gave everyone kind of a background in the importance of, or what biomarkers and pharmacogenetics are. And the recurrent theme is targeted treatment and really honing in on that individualized care. I'm going to give Leah a couple of minutes to tell us her story before we move into the actual testing. I know that we're going to have some questions, so welcome, Leah. Thank you for being here.
Thank you for having me. I appreciate the chance to share my story. My experience with biomarker testing started in December of 2019 when I was diagnosed with stage 4 lung cancer as a never smoker. When I was in the hospital and first diagnosed, of course, you want to start treatment right away because the cancer's already spread from my right lung to my spine and pelvis. So the oncologist that we met with suggested that we go ahead and start one of the standard protocols for lung cancer treatment. My husband, being the researcher that he is, felt like there was more to the story. Someone that's never smoked shouldn't have stage 4 lung cancer in theory. Which led him to do some investigation on his own, where we spoke to a second oncologist who said, please do not start any kind of treatment until biomarker testing has been completed. We know that the time, and of course this was December 19th when I was diagnosed, so we have all the holidays in there. We know you're anxious to get started on treatment. but please don't, because if in fact you do qualify for a targeted therapy, it may not be as effective if you've already had traditional chemo. So I had biomarker testing done through Caris Labs. My particular biomarker testing was $20,000. We actually pulled the bill up for that when I was asked to kind of give my perspective on this. So when we were in the hospital, I was in the hospital for a total of 8 days. My husband, bedside, as I'm basically recovering from an emergency chest tube, multiple biopsies, bronchoscopies, you name it, I had it done. He spent 80 to 90 hours on the phone with insurance companies, with other oncologists, trying to figure out, do we have access to this biomarker testing? Which we did in fact have access to, but that was definitely stress that we did not need on top of dealing with a cancer diagnosis and our children and whatnot. So the biomarker testing did reveal that I have a genetically driven cancer, which is EGFR exon 19 as my driver, which was in a lot of the different PowerPoints. Because of knowing that biomarker testing result, I qualified for a targeted therapy, which was called osimertinib or Tagrisso. Starting that medication, it started about 3 weeks once with my original diagnosis. It took about 3 weeks to get started on that therapy. Since then, my primary tumor shrunk by 70%, and all my bone metastases totally have healed. And that point, a year later, we decided to be pretty aggressive and do 8 SBRT radiation therapy treatments to my primary lung spot. And at this point, I'm considered no evidence of disease and stable. In my journey of lung cancer, it's kind of a lonely cancer in terms of, especially someone my age. There are not a lot of young, healthy, non-smoking women walking around with stage 4 lung cancer. Luckily for me, I had 2 other patients in Kentucky. One is a patient at UK Marquis. One was a patient here in I'm from Louisville, was in Louisville as well. And the one I'm speaking of now, her name was Elizabeth Moyer. Many people may have heard of Elizabeth or her story. She was diagnosed at age 30 with stage 4 lung cancer. She was a college athlete. She had never smoked, and her youngest daughter was only 6 months old at the time of diagnosis. Elizabeth and I became very close friends, and I was actually with her just hours before she passed away. For us, she had a genetic driver of ALK positive, was her genetic driver. For those of us with these genetic drivers, a lot of times our cancer, we do progress. We are never going to be in remission, if that's what you want to call it, or totally cancer-free. It will come. It's not if it comes back, it's when it comes back. Every time we progress, we need to have this biomarker testing repeated to see if we have another driver and what therapies would be best suited for our particular cancer. Elizabeth had over 6 biomarker tests ran, most of which were out-of-pocket expenses. So it is extremely important that not only is the first time people know, doctors know, patients know, the first time you're diagnosed, you need to have this biomarker testing, but the doctors, the patients, all of us need to know that before we do a second set of treatment or move on to another therapy, that we have this this biomarker testing, repeated. I'm here today because I feel strongly of having a whole team approach, that all of us need to be on the same page, doctors, hospitals, patients, oncologists, everyone, to get the testing we need to have the best life possible, even in terms of quality of life, but also longevity of life. I have my kids here today, and this is why we're here. It's because this testing allows me to be with them. Cancer's hard, cancer's scary, and we don't need to be worrying about whether we're getting the right treatment. We just need to know this is the best treatment for our disease. Thank you.
Thank you. Thank you for being here, and we're ecstatic that you are here, and this is the point. We want to make this more widely available. And I want to give Mr. Remington, who came down from Northern Kentucky, a few minutes to talk about the actual testing. And if you can just give kind of a high-level overview. I know we're going to have some questions and maybe about the specific testing.
Good morning. Very humbled to be here. Tony Remington, founder of Gravity Diagnostics. We're a CAP CLIA laboratory in Covington, Kentucky, licensed in all 50 states.
Will you pull your microphone
sorry.
just a little closer?
Yeah, sorry.
Yeah, thanks.
Hello. Is it working?
Is it on?
Nope.
I usually talk fast, but after all the other
even better.
speakers, I feel like I'm going to be the slow one here. Thank you for having me. Very humbled to be here. First time I've ever done this. My name's Tony Remington. I'm the CEO and founder of Gravity Diagnostics in Covington, Kentucky. We're a CAP CLIA laboratory licensed in all 50 states. We do all of our testing, all of our work in Covington, Kentucky. So we can get a sample from anywhere in the United States by 4:30 a.m. because we have a partnership with UPS. We're lucky to have UPS in Kentucky. That's their world airport hub. So basically, from my point of view, after all these amazing speakers, it's kind of hard to talk about pharmacogenetics when we're talking about cancer. And but I'll just kind of do my best to intertwine the two. I think from my point of view, I'm in the private sector, and our main model of sustainability to help people is billing insurance and getting paid by insurance, similar to like Quest or LabCorp. So before the pandemic, we do pharmacogenetics, we do toxicology, we do blood, we do microbiology, any type of tissue, any type of sample, whether it's a swab or blood or urine, et cetera. We do a ton of medical monitoring, a lot of addiction and recovery customers, trying to help those patients, recover. And because of, the role I play, I'm not a physician, I'm not a clinician, I look at it this way. I'm like, how do I save the healthcare system money? The way to, get people more interested in doing this and helping out and supporting payment is, I think that the healthcare system is very reactive, and we end up spending a lot of money on things in a reactive way. And I think if you do more investing on the front end with pharmacogenetics and next-gen sequencing with cancer, we can do that. We have next-gen sequencing technology as well in Gravity. So, we kind of came at it where we're spending a lot of money on healthcare, a lot of money on addiction, a lot of money on recovery and mental health. And I think if we were more proactive about that approach, we'd actually reduce the cost to the healthcare system. I'm trying to figure out how to do this. How do I just go like that? Sorry. I do about 10 conference calls a day, so I don't know why I can't figure this out. Okay, thank you. Yeah, now you're setting me up for failure here. So, so I went over who we are. You did an amazing job talking about pharmacogenetics. The way I simplify pharmacogenetics is it looks at how you metabolize medication. I've covered the United States for 25 years in the healthcare industry, so I've met thousands of physicians over this 25 years. And you'll find that most doctors and clinicians that work with behavioral health or pain management patients admit that it is a trial and error approach. Like they'll openly say, it's like throwing a dart at a dartboard or spinning a roulette wheel. That's very common. And my passion and why I got into the laboratory diagnostic industry and left kind of more of the medical device industry was we've got this amazing opportunity to get this information. It's a benign test. It doesn't have any adverse events, and it could prevent a catastrophic adverse event. It can get the right dose and drug the first time. And it just, to me, for 10 years, I've been like, why are we not doing more with this? So I have been involved in this field for 10 years. And basically, I, just wanted to explain what pharmacogenetics was. My passion for this is that if you could, even before all the stuff we know about now with opioids, like I feel like if you can get a patient that needs a prescription for all the right reasons, a pharmacogenetic test on the front end, you could, have a better chance of getting the right drug and dose, prevent cost, trial and error, drugs that don't work. One thing that no one mentioned, there's actually drugs that you just can't metabolize. So you can be on a drug and just not metabolize it, period, no matter how much you take of it. So it's really important to get this information. And we've been passionate about this for a long time. There's data out there. There's no, you will run into really, really well-respected clinicians that say the evidence isn't there yet. The peer-reviewed 5-year randomized trial data is not as strong as some people might like it to be. But there's a lot of data and proof sources out there that this works and that, you can save the healthcare system money. at Gravity, we developed our own internal report. So the way our lab works, we have all the equipment, we have all the instruments, we have 75 scientists, or science-trained employees. We once we run the sample, the patient gets this report, and the clinician will get the report that ordered it. We created this, kind of simple, like red, yellow, green light system. So it is 20 pages. The patient will bring it to their clinician, and want an expert to go over that. And we always say this gives you implications. You never want a patient to get the report and actually change their drug or dose, right? But this gives them training wheels guide to try to get the drug and dose right the first time. And we wanted to make this report so anyone in the room could understand it, right? So if all your drugs are green, you're okay. If they're red, you probably want to talk to your doctor. And that's all. Thank you.
All right, thank you. I think that this presentation overall has given us some pretty clear and convincing evidence that this works. And it's my understanding for the most part that the actual testing is a one-time test. Is that correct?
I like how you said it earlier. I mean, we usually say that. I think there's some scenarios where if you have like a transplant or some sort of, event, you might need additional testing, but yeah.
Okay, all right, thank you. Senator Alvarado.
Thank you, Madam Chair. And I see members of the KMA here today. Hopefully I can get an hour of CME for this lecture because I find this stuff fascinating. I know some of our members of our committee may not. It's a lot of science, and this is stuff that, for me, I think is the next step of where we're going in healthcare. We often will look back probably in 20 years and think, why weren't they doing this stuff when they could have been? And we're going to be looking at the old way of doing chemotherapy for cancer treatments is just barbaric, which, like you said, just trial and error, try it, see what works, see what kills people, what doesn't, and try to advance the next step. And we're getting a lot fancier at this. Leah, I'm impressed by your story. My wife was 44 when she was diagnosed with breast cancer. It is scary, even for a medical family. A lot of bad memories for me going through that. You feel helpless because you can't do anything for your wife. And so it's tough to do that. I know men tend to want to take control and figure things out. I'm sure your husband's in that same role. I found myself in that same role. And I would go to her medical visits only to have the doc eventually say, is it okay for him to be here? And I'd say, you know what? I need to just step out and let her kind of do her own thing as a patient. So it can be very difficult. So I'm glad that you're here and glad things are working out well. Had a very good friend, we were just commenting, Dr. Naren James was a physician, vegetarian, guy in fabulous shape, stage 4 colon cancer, died from it, went to his funeral about a year and a half ago. I'm sure this would have helped him as well for a lot of this kind of testing because there was nothing else that really triggered for him for that. The reason we're even covering this topic, for those who are wondering why are we going over this, we're trying to get coverage for these tests. Some of our insurance carriers are covering tests, some are not. And so we're trying to make this across the board. On pharmacogenetics, I think it would require a once-in-a-lifetime test, and that gives you and your doctor the pathways that you can use for drugs and treatments and what's appropriate, what's not, what works better for you. Well, I can drink, probably not healthfully so, 6 to 8 cups of coffee a day and not have the same effects as a half a cup for you because my pathways, I'm sure, are different in that regard. Early detection. Dr. Mullet, I think you shared a little bit of a personal story as well. I'll share mine today. Got diagnosed with a DVT about 5-6 weeks ago. Currently on thinners, not really an explanation for it. I kind of diagnosed myself, contacted my doc, said, hey man, I think I probably need an ultrasound. As I'm laying there, I see my DVT. Blood, what goes to your head? Hypercoagulable states, it could be a malignancy of some sort. So fortunately, everything came out okay, but I went to a company called Grail.com, which Grail now offers a lot of pre-testing, and so they offer this kind of marker testing. Very high specificity, so if you're negative for cancers. But the sensitivities are probably anywhere from 30 to 70% depending on the tumor type, and they're trying to get fancier the more data they collect. I went ahead and paid for that test to get screened to say, okay, if I got to go look for a cancer, let's find out where that targeted location could be. And it came back negative, fortunately, so I feel very good about that. Not having any other symptoms. But as those tests get fancier, we can start using those tests as a marker, almost as a pre-diagnosis, or to start catching things at a very early stage. And so I know a lot of our MCO friends or insurance company friends are watching and listening to this and thinking, how much is this going to cost us? I'm going from it, how much is it going to save you? If you catch something at a stage 1 level, you can get that thing out and avoid the years of potential chemo treatment, hospitalizations, et cetera. For me, it costs $950 to get that test done. And it's getting fancier as we go. So it's not quite the $20,000 test that you're talking about. And the more we do it, the more we're going to see that price drop and come into range. So I think, again, it's very important to look at early detections on these kinds of things. A lot of these are after people get diagnosed. It's the biomarker testing to direct therapy. We have that availability. There's also now an availability to look at this stuff prior. Now, you might have to, that isn't a once-in-a-lifetime test. You have to get them repeatedly because things can change. You develop a new tumor or cancer. Now the markers are present in your bloodstream, and you have to get those done. But I think there's an opportunity for that, and obviously people in your family that might have a potential for this, we should be able to cover those tests at least for those folks to make sure that's done. In Kentucky, we're making a lot of success. Saw the reports from our physicians and our pharmacists who presented a lot of the information and where Kentucky is trending. We've been a bad state for cancers. I think we're starting to see some light at the end of the tunnel. I know our colon cancer diagnosis rates are going way up. We've had a huge effort from the state funding towards that. Now we're doing it towards lung cancer. Major opportunities to make some strides in this and be a leader on this, I think. And so again, I know if we propose this, I know there's legislation that we're planning on bringing forward this upcoming session. I know those who will try to oppose this. And again, I would encourage you, think of how much you're going to save on this if we catch people early in a state with as much cancer as we have, instead of treating people on the back end of this. Catch it early, get it out early, get treatments early, and avoid those hospitalizations and not to mention the deaths that we're going to have if we don't catch it early. So I just wanted to get that out there. Madam Chair, I appreciate you letting me rant a little bit, but thank you all for being here. It's really important stuff. It's the next step, really, of healthcare going forward in our country.
There is nothing I can add to that. Very well said, and I agree completely. Senator Berg, do you have a question?
Thank you. Actually, I think this is, for me personally, one of the most fascinating presentations that I've had up here as a state senator, and I really want to express my appreciation, first of all, to whoever is writing this bill, and to you guys for coming up and sharing this extremely important information with us. I have a question, and then I have a couple of comments. I'm going to start with my comments first. I personally was diagnosed with breast cancer at the age of 47. I had the unfortunate experience of diagnosing my own breast cancer. And at the time, had excellent insurance. I mean, really, I cannot believe how good my insurance was and what a blessing that was. The only thing I really had to pay out of pocket for was the genetic testing on my tumor. And if I remember correctly, I think I paid $1,300. It may have been $2,300. It was around there. And for me, I paid it happily. But think about how few people in this state get the option of making that decision at this point, because it's not covered by your insurance, and therefore it is out of reach to you. In my case, this genetic testing was actually able ultimately to impact my decision making on chemotherapy, and actually saved me 2 rounds of chemo, which would have cost a heck of a lot more than that $1,300 that I put out of pocket. Much, not even to talk about quality of life and everything else. So, I mean, for me, it was essential. I have a friend right now who is battling, stage 4 breast cancer. Every time they biopsy her, her genetics are changing on this tumor, and every time it changes, they are able to change her targeted chemotherapy and preserve her life, because she's responding when she never responded before. And every time she calls me and says, do I really need to spend this money again? My answer is absolutely yes, because it has that much of a potential impact on your treatment and your outcome. And personally, I think the fact that these aren't covered by insurance companies at this point is a real shame, because they do impact treatment and outcome. I want to make sure everybody in this room understands this is important business. I mean, I can just very quickly, I want to share, being a diagnostic radiologist, I've been looking at non-small cell lung cancer, I say my whole life, but for the last 35 years, I know exactly what it looks like. I mean, I can look at a study and I can tell you exactly what it is, even before we biopsy it, because it is so typical. And to now watch it not only disappear, because we used to see it disappear, and then it would come back in 3 months. The disappearance was very short-lived. Now we watch it disappear, and literally we have patients that year after year, it's not coming back. And I look at these studies and I think of what I experienced as a diagnostician just 20 years ago and the difference that this is making. It is amazing just to watch these images. Now I have my one question that I am going to ask. Does anybody up here speaking have any idea if we can use any of this pharmacogenetic testing to try to predict addiction to alcohol? Could we screen people and let them know that you have a genetic predisposition, which we know exists, to becoming addicted to alcohol? Because I think that information, if we could find it for people, might really be a game changer.
I mean, my only answer would be, I'm not I have a great group of PhDs that would probably give you a much better answer. I think the predictability, there's going to be algorithms that you use where you use, all the demographics and the genetic results and your zip code and we're working on those type of things. I can't look you in the eye and say, yes, that's happening. But I think because we do so much addiction, you feel like that would be that's a missing piece. So my answer is I think it's possible, but I can't look you in the eye and say that, it's coming tomorrow.
Thank you, sir. Did you have another answer?
No, I was going to say something quite similar to that, in so much as I don't know that we can say directly right now, but that the information that's provided by this type of testing into this line of thinking and research will provide that answer. I'm fairly certain of it.
And the only thing I want to add is the cost to do this is so much different than it used to be, in a good way. The cost, 10 years ago, insurance companies would pay, $10,000 for testing if it was in network, and we, that was just, that was not my lab, when I represent other labs. You're talking hundreds of dollars to do pharmacogenetics now. So, if you want some advice at that point, when you look at this, and I think same thing with next-gen sequencing, it's much more expensive to do that. Your cost of goods are probably 5 times higher at least to do, cancer versus pharmacogenetics, but it's not $20,000. So, I think there's hope here that this is affordable and it will cost justify itself, as you all mentioned. So.
Thank you.
Thank you. That was going to be my question, so I appreciate that answer. Senator Kerr?
Thank you, Madam Chairman, and I think all of us understand now why your co-chair talks very fast. It's all that caffeine, I guess. I appreciate you being here very much today, and I'm not sure who exactly to address with this question, but my son is 37 years old. He has 4 friends, contemporaries, who are 40 and under, one a teenager, one 25, one 29 or 30, and one 40, who have all been diagnosed with colorectal cancer. And they're all 4 from Kentucky, although they're from different areas of Kentucky. They are all 4 non-smokers. I'm just curious about your knowledge and your expertise and your statistics on young people and colon cancer and why we are not recommending colonoscopies for people younger than 50, and what would these genetic markers possibly be of benefit, and should we be looking at this age range more?
Well, I thank you for your question, Senator Kerr, and I think that it is important that we understand that there are genetic drivers that are present for many of these tumors, colon cancer in particular, and Kentucky has a high population of patients with what's described as Lynch syndrome. It's a genetic driver of types of colon cancer. There are polyposis syndromes that exist, often familial, but many of these are sporadic. They would be developed because of, again, a mutation that develops. Perhaps there's some process there. The recommendation now is for 45 years old for colon cancer screening to begin. And, I think as we look at this, even in lung cancer or other factors, there are risks associated with moving that screening earlier. The risks of undergoing a procedure that may not be necessary, that may cause problems. And so we really have to stay within the guidelines for that. But I do think as our genetic testing expands, there's a few features that we haven't really touched on here that I think are critical. One is that that as we develop these tests, the reason we didn't do this 20 years ago, Senator Alvarado, was because it took far too long for us to get this results from the genetic testing. And now it's down to just a couple of weeks, and soon it'll be even shorter than that. But the other piece of this is that this information endures, even though our development of new drugs and new testing is evolving. And one of the interesting features, I think Caris Labs was mentioned, and one of the features that they've talked about is holding on to this information on patients. If there's no actionable mutation that's present, but there's a mutation that's there, a drug develops a year down the road, they can look over that library and say, Dr. Millett, you had a patient last year that had this mutation. Now there's a drug that's available. You might think about this in the conduct of your care. I'm a surgeon, so it's a medical oncologist that would be doing that. But they might call me because I was the surgeon that perhaps diagnosed an earlier stage disease. And so I think that this information is persistent. And so it's really important that we have the ability to look back on it. And the final piece about this is that genetic testing for families and genetic testing for patients accumulates this data. And so we'll begin to look at patterns of treatment that are effective if we have more patients that undergo these tests. If we don't open the door to let these tests happen with less barriers, pre-authorization, the cost associated, financial toxicity for patients, and so forth, then we won't get that information that will give us the patterns of treatment that will allow us to direct care in more precise ways.
All right. Thank you so much. I really appreciate this presentation. We do have a couple of more questions, but we also have 2 more presentations. So I'll give everyone an opportunity who has indicated that they have a question, but we're going to have to speed things up a little bit. Representative Bentley.
Thank you, Chair Lady. When you do a tumor tissue molecular test, how long is it taking you to get your information back? First question. You said 2 weeks. 2, how many markers is FDA looking for before you can begin therapy? And 3, is Foundation Medicine the only standardization test you got?
I could take that question if you'd like.
Thanks, Joe.
So the advertised turnaround time is 2 weeks. That can take a little bit longer depending on whether it can get out of pathology quickly or not. But the goal is to turn it around in 2 weeks. I'm going to go to your third part of your question, whether Foundation Medicine is the only test. There are a number of commercial providers that I would consider would be standard care, including Caris, Foundation, Tempus. And most of those are paid for by Medicare. And varies a little bit with private insurance. And then with regard to the number of genes that are on the test, that varies a little bit with the test, but it ranges from about 350 on Foundation up to more than 500 on a Caris. And the other thing, the trend in testing is to do the whole exome. So that basically, you cover every single gene that's available, and then you report back on the ones that have mutations. So I would anticipate to see more and more and more genes come back and have larger and larger panels. So that's a clear trend.
all of it.
Okay. Quickly.
On your monoclonal antibodies, is mutation the only thing you see that's causing that resistance?
I guess I could take this one too. There's a lot of different resistance mutations. There's also a lot of changes in the tumor microenvironment, and I would say that that area is still really evolving. We don't really know all the answers to that yet, but that also to me encourages further testing, because the other trend is that a lot of this testing is going into large databases and persisting, like Dr. Mullet was describing. So the more testing that we're able to have, the more repeat testing, especially after immunotherapy, the more likely we are able to identify those resistance patterns, which are generally used by pharmaceutical companies to design new drugs.
Thank you, Chair Lady.
You're welcome. Okay. Representative Frazier, do you have a quick question?
Yes, I just have a comment in regards to Dr. Mullet's presentation, showing the success in encouraging lung cancer screening and the success that we've had there. And I just want to make a comment group is that we really need to look at these screening measures being covered, not subject to deductible. Some plans cover it, some don't, and you can't ask a group of asymptomatic people to go get these tests knowing that they're going to get bills in several hundred and $1,000 range.
You're right. Okay, thank you. And then last, Representative Birch. Yeah, your microphone is not on.
Is that better? The question I'm going to ask is, do you pay attention to the patient? And I will tell you why I'm asking the question. Is my own personal experience. I went to dermatologist several times, and he gave me a clean bill of health. And the last time I went, I said, "Doctor, what's this?" "Oh, I didn't see that." And I had a melanoma. It was removed. Then I, believe it or not, I went back to this guy, and he gave me another clean bill of health. And I said, "What's this on my nose?" "Oh," so he removed another one. And then a friend of mine went to a doctor and asked him, he had passed blood in his urine. And the doctor says, "No problem." I said, "Jim, I know 2 friends of mine died because they were getting blood in their urine. You better get a second opinion." He went to Cleveland Clinic. He had 2 cancerous tumors in his bladder. He is now going to Anderson in Houston for another opinion on it. And but the last thing I'm going to ask is, because it's very personal, is my son went to a dermatologist 2 years ago and complained of a problem here with his arm. No problem. He now has stage 4 melanoma. If the doctor had listened to him and paid attention, he probably would not be fighting for his life today. And I was wondering, how much emphasis do doctors pay on listening to their patient, or think they know it all and blow it off? And I'm not faulting any doctor, because I have the greatest respect for them. But I would say one other thing is, the next dermatologist I went to gave me some medication, and it cleared up the problem that this other doctor wanted to charge me $10,000 a month to take an injection for. And it cleared up that problem. Now, how much attention do you pay to your patients when they complain about something? Or
Well, I think all of the tests in the that we can do, even these advanced tests that we're talking about, the CT scans for screening, PET scans, and other tests, don't make up for someone who doesn't care for their patients. And so I think that we should start, and we do with medical school, and we start with all of our topics, that it should begin with the patient, and all of these other features that we're adding on should be guided by our history, by our physical examination, by our training, by our personal experience, but ultimately by caring for the patient to be able to recognize that these are that, as Leah has described, there's a human behind this DNA test that we're doing. There's a family behind that patient. And so the more we recognize that, the more important these tests are. But I certainly recognize your point and recognize that we need to continue to hone those human skills as well as our science.
Yeah, and I can add to that, Tim. I mean, really listening to the patient is key, and it's never unreasonable to get a second opinion either.
And I'll just say as a non-clinician, I mean, I think medicine's complex, and there's a lot of endpoints that a clinician has to deal with today that they didn't have to deal with 20 years ago. So I have a ton of respect for providers and also the insurance companies. I mean, they're all trying to get it right, but it's so complex now for a clinician that, they're on a clock, they got 10 minutes, they get another their model is so different than it was a long time. You know what I mean? So I think you're right. I mean, things fall through the cracks, but I don't think it's due to a lack of caring. I think it's a complex system right now for to be a clinician. So.
Yeah, I just want to thank everyone for this great conversation. I think that you just brought it full circle, and we understand the complexities in medicine. We understand the need for progress and to put some policies in place that make sense. We certainly need to take into consideration the patients, the providers, and the insurance companies who are trying to do this right, trying to provide coverage in a way that makes sense. And so that's really what this discussion was about. That's what the upcoming legislation will be about. And I just really want to thank everyone for being here today. This has been great. Thank you.
Thank you.
Thank you.
All right, we are really honored to have with us the Kentucky Hospital Association. Nancy Galvani is here, and thank you so much for your patience in putting up with I knew that we were going to have a lot of great discussion around that topic. Went a little bit long, but thank you for being here. Nancy's going to talk a little bit about the relatively new federal transparency laws, what that is, and what it means here in Kentucky. Nancy, thank you for being here. Just introduce yourself for the record and proceed.
Thank you so much, Chairwoman Mosier, Chairman Alvarado, and the committee members. And it's a great presentation and certainly a very important topic. So no problem at all. Happy to have listened to that. So thank you for having us today to talk about the important issue of healthcare transparency and what hospitals are doing to make prices more transparent. And of course, when we talk about transparency, we're really focusing on making available information to consumers so that they can shop for care. But what patients really want to know is, what is the cost going to be to me? And so something to keep in mind is that the patient's out-of-pocket costs aren't determined by the hospital. Either the patient's private insurance plan or the government program that covers the patient is determining the out-of-pocket costs. And a patient's insurance company really is in the best position to tell the patient if they've met their deductible, whether the provider is in network, and what the patient's out-of-pocket costs are going to be. Kentucky hospitals really have a long history of helping our patients anticipate their out-of-pocket costs and pay for them. Our hospitals have financial counselors that provide estimates on request, and hospitals have financial assistance policies to help the uninsured, the underinsured, and low-income patients pay for hospital care. But on top of all of that, there are several new federal requirements that hospitals and other providers have to meet to make prices more transparent. Last year, the federal hospital price transparency rule took effect. Although hospitals have had their charge masters on their websites for many years, this rule now requires hospitals to post 5 types of standard prices for all of the items and services that are offered by the hospital. And these include the gross charge, the discounted cash price, the hospital's negotiated price by each third-party payer that they have a contract with, and the de-identified third-party payer minimum and maximum negotiated price. This information must be displayed in a machine-readable file that's located on the hospital's website that's downloadable, along with the description of the item and any code used for billing. And I've actually gone out and looked at these files, and as you can imagine, they are voluminous and not helpful to any patient attempting to understand their costs for hospital care. The files will also naturally differ by hospital due to the presence of different payers, hospital participation status, and the different contracted payment methods that insurance companies use, such as DRGs, payments based as a percent of charge, or an all-inclusive daily rate. A second part of that rule is intended to be more useful to patients, and that's where our hospitals have put most of their efforts and focus. CMS requires hospitals to post prices for what they call shoppable services. Shoppable services are services that can be scheduled in advance and are in non-urgent situations. CMS has specified 70 of these shoppable services, and then they require hospitals to add another 230 to make a total of 300 shoppable services that they have to post prices for. In lieu of posting the prices for these services, a hospital can develop an internet-based price estimator, and nearly every Kentucky hospital is using this method. Our hospitals are working diligently to meet these new federal requirements. CMS recognizes the heavy IT lift involved in doing this, particularly to our small hospitals that have to rely on vendors because they don't have IT staff in-house. So CMS has been working collaboratively with the hospitals to achieve compliance. The compliance deadline for the machine-readable file of standard prices was delayed until July 1st of this year to align with the Federal No Surprises Act, which I'll talk about in a minute. There are 6,093 U.S. hospitals, and as of June this year, only 160, that's 2.6% of all the hospitals in the nation per CMS, were not in compliance with that rule. When a hospital's found out of compliance, they get a warning letter and are then given time to come into compliance. The Federal No Surprises Act also instituted a number of new rules for hospitals and other healthcare providers addressing transparency. And although the law technically took effect January 1st of this year, many of the provisions have been delayed because CMS recognizes that the infrastructure for them does not yet exist. One provision that did come into effect is the requirement for providers to issue a good faith estimate of expected charges to uninsured and self-pay patients. A self-pay patient also includes a patient who's insured but is not going to be using the insurance to make payment for the service. A good faith estimate is a notice of the person's expected charges, including any discounts or adjustments, such as through a financial assistance policy that the hospital would have. These estimates can be requested, but they are required to be provided upon scheduling of a service. An individual has the right to go through a new federal dispute resolution process if their actual billed charges are substantially in excess of the estimate, and the federal government defines that as a charge that exceeds the estimate by $400. And this diagram kind of shows this new process. This year, each individual provider is required to submit their own good faith estimate to the patient. So, for example, if a patient is having outpatient surgery, the hospital scheduling it would provide the hospital's estimate to the patient. But the patient would have to go to the other providers involved separately to get their individual estimates, for example, the surgeon. That changes next year. In 2023, the scheduling provider is considered the convener and is responsible for notifying any co-providers or co-facilities, getting their estimates, and presenting a consolidated estimate to the patient. So on this slide, you can see the hospital would be reaching out to the surgeon, the pathologist, the anesthesiologist, saying, this procedure is being scheduled, you need to send in your charges, and then the hospital would have to put all that together in one good faith estimate to the patient. There are very tight time frames involved, with only a few business days allotted by the federal government for this communication and exchange of data to occur. And as you can see here, it's basically 1 business day to turn all that around, 3 business days to get the information back to the patient. There's a totally different process that will apply to insured patients. When a provider or facility notifies an insurer that an enrollee is scheduled to receive a service, the provider will send a good faith estimate of expected charges to the insurer. The insurer will collect the information from all of the providers involved and will give the enrollee an advance EOB or explanation of benefits. That will tell the enrollee the network status of the provider, the contracted rate, and their expected out-of-pocket costs based on the individual's plan. CMS has indefinitely delayed implementation of this advance EOB until CMS issues more regulations on how data will be exchanged between providers and plans. CMS has just issued a request for information on September the 16th, seeking comments on standards, provider burden, and a whole host of issues related to this requirement. Now, there's several factors that have to be considered when we talk about hospital prices. First, we have to recognize that healthcare does not operate in a free market. Essentially, healthcare costs are dictated by the federal government. The Federal Emergency Medical Treatment and Active Labor Act, what we call EMTALA, requires hospitals to treat anyone who comes through the hospital's emergency department regardless of the ability to pay. Kroger, Best Buy, Walmart, any other business would quickly be out of business if they were required to provide their goods and services to anyone who walked through their doors regardless of ability to pay. 80% of the patients in Kentucky hospitals are covered by a government program, Medicare or Medicaid, neither of which cover the full cost of care. They cover between 85 and 90% of the cost, not the charged amount. Normal businesses in a free market could not operate, much less make a profit, if so many customers were paying less than the business's costs. Hospitals have narrow lines of service, such as elective surgeries, where the revenue from that service covers all the other money-losing services in the hospital, such as obstetrics, NICUs, and emergency departments that communities need. By necessity, hospitals are forced to cost shift to a small pool of patients who have private insurance. But even the ability to cost shift is severely limited because Kentucky has such a consolidated health insurance market. In Kentucky, 2 insurance companies dominate the market with 90% of the market share between them. And that means that hospitals have little negotiating power when it comes to the negotiated rate insurers pay. Now, the truly good news is that despite all these issues that tend to cloud pricing, Kentucky, according to financial advisor Motley Fool, is the least expensive state for health care. And this is in line with many other reports over the years, including from the Rand Corporation, showing Kentucky consistently with some of the lowest prices in the country. Even though pricing data is becoming available, the incentives for patients to shop for services is misaligned and unlikely to produce the desired results. Simply looking for the least expensive service may be a great benefit for the insurance company, but there's really not much incentive for the patient. Patients typically look beyond price to quality and what their physician recommends for that patient's unique medical needs. Shopping for a surgical procedure isn't like comparing one Honda Civic to another one. Keep in mind that hospitals are reactors within a system created almost exclusively in Washington, D.C. Even the state Medicaid program, which is a federal-state partnership, is completely dominated by Washington. Medicare was instituted in 1965, but the program hasn't really changed much in more than 50 years. What has changed are the mounting regulatory burdens placed on hospitals and providers that continues to make the system more complicated. All hospitals must employ armies of staff to handle the highly specific billing system for reimbursement. And these administrative burdens are being compounded with the growth of Medicare Advantage plans, escalating prior approvals, audits, denials, and appeals required by third-party payers. And that kind of overhead contributes significantly to the cost of running a hospital. So those inside the hospital charged with dealing with these administrative burdens laid on them by the federal authorities and the insurance companies are highly sympathetic to the difficulty that patients have in navigating the healthcare system. KHA stands ready to help you understand any of this information. And thank you so much for letting us testify today.
Well, thank you. This is a very complicated system, and the more we dig down on it, the less I realize I know. And so I appreciate this overview. I appreciate your work in making this more easily understood and usable by consumers. I know that some states have right to shop websites, and I'm not exactly sure how they get there because it is so complicated. So I don't know that I have any real questions right now, but I would like to really figure out how to make this a usable tool so that, when we look at the cost, or the charges are different than the cost, which you alluded to, and so I think that's important to note. And I don't know if the actual cost will be part of this transparency, or how also to make it more usable for the patient, but usable for us when we're looking at how do we actually reduce healthcare costs for our constituents. Do you have any thoughts about that?
Well, I'll say a couple things. The machine-readable file, which of course is a nightmare if you try to look at it, that wasn't designed for consumers, but that's designed to be downloadable, and we believe shopping tools are going to be created from that. So we think this is really in its infancy, and these things are only now starting to be developed. And of course, with the whole advanced EOB, I think that will be very helpful to individuals, because that's really going to tell people what they want to know, what's it going to cost me. But again, we have to figure out how all that communication is going to happen to where that, all those estimates can come in, and those good faith charges. And then the insurance company is going to look at my plan, what's my deductible, and tell me what I need to know. So I think the market hasn't had time yet to adjust to all of these things, being out there. But I think when you look across, there's a lot going on here, as you can see, between the machine-readable files, the online price estimator. Anybody can go out that. You don't have to register. You don't have to sign up. You just go online and put your information in. That's going to give you a good idea of what your cost is going to be. And then, of course, if you have a specific procedure, you can reach out to the provider. The uninsured, the self-pay. And in the self-pay, there's a lot of people with the high deductible plans. They fall into this group that today, can get that information. So we really feel like there's a lot going on, and we need to stop and let this play out and see, what else do we need before, quite frankly, we feel, we pass any more requirements.
Okay, thank you. That is good to know. And I appreciate your coming here and giving us an update. And obviously, we need to bring you back in at least in another year. We do have a couple of questions. Sure. Representative Raymond?
Yes, thank you. Right.
Oh, sorry.
I wanted to ask if this will affect, it seems like it can take hospitals so long to get bills out. So will this help, this sort of pre-work process, help get bills out any faster? Are there any regulations about the speed or pacing of billing? Anybody who's had a baby in recent years know there are so many bills from so many places. They trickle in, and you never know when they're done, right?
Okay.
Right? My baby's almost 3. I would not be surprised to get a bill for her delivery. So will this...
That's a billing problem.
Will this, or is there something else we could do to ensure that people know that they'll receive all the bills that they're responsible for in some limited period of time?
So I'll say this. Certainly, the advanced EOB for insured patients, that's going to list everything that's on there. It's not, you're going to get one for the hospital, one for something else. This idea of the convener, where today, for the good faith estimate that starts next year, the hospital, if you were going to the hospital would be giving you the total charge, the hospital charge, the obstetrician, whatever would be on there. That's going to be on, one good faith estimate. For the insured EOB, that's going to be the same thing. It's not just piecemeal by provider, but it's going to be consolidated. So I do think that would let you know what's expected, because here's the other thing. Today, with the good faith estimate, and next year, today, it's not consolidated. When that becomes consolidated, and everybody gives their estimate, the hospital, the physician, the anesthesiologist, whatever. Everybody has to be within $400 or that individual has the right to dispute it. So I think, that's going to put everything in one place of what is normally expected. Now, there's disclaimers on there. Something happens, out of the ordinary. So, people aren't going to be held to that. But generally speaking, they will be.
Okay, thank you. And then Senator Meredith, we'll wrap up with you. And we're going to stay a little bit late to hear from our friends at the KMA too. So thank you.
Thank you, Madam Chair. I can be brief. This is one of the worst examples of government overreach I've ever seen in my lifetime. It does absolutely nothing to improve the quality of care rendered for anyone. It has no value to the consumer. The average consumer is not going to use this information, so we're spending literally millions of dollars to provide a database that has no value to anyone. It's ridiculous. Appreciate your presentation, but one of the points that you had I thought was most interesting was on our commercial market that it's monopolated by 2 carriers, but yet we have 6 insurance companies that want to manage our Medicaid program. Don't you think that's rather ironic? And can you give maybe some insight as to why there's that disparity between the current commercial market and Medicaid?
I can't really comment on that, but you make a good point.
Thank you. Thank you, Madam Chair.
All right. Thank you. All right. Thank you, Nancy.
Thank you. Appreciate it.
All right. Okay. Next, we have our friends from the Kentucky Medical Association. Dr. Mona Lisa Taylor is here to talk about prior authorization requirements and some legislation that we filed last year and are continuing to talk about. So I appreciate your being here. Please introduce yourself for the record and proceed when you're ready.
Thank you, Chair Moser, Co-Chair Alvarado, and members of the committee. For the record, my name is Dr. Mona Lisa Taylor, and I'm a board-certified internal medicine physician and the current president of the Kentucky Medical Association. It's an honor to speak to you today regarding prior authorizations. Now, just some background. The earliest iterations of prior authorizations date back to the 1960s. This is when a lot of patients ended up in the hospital and required treatment there and confirmed diagnosis by 2 physicians before they could get treatment for their medical condition, like diabetes. Now, at the time, they started utilizing prior authorization as a check on medical necessity for services and treatments provided. And as quality of care improved, our care moved out of the hospitals, and now we're in more outpatient settings. So prior authorization also changed, and now it's required for basic services, procedures, and medications that I utilize to help take care of my patients. Now, in 2022, this is a health plan cost control process. Physicians, other healthcare providers have to obtain advanced approval from a healthcare plan, and you have to provide them a certain amount of information to get your service or medication delivered and approved for the patient. Now, this sounds really simple in concept, but unfortunately, it gets really complicated and convoluted, and it can be extremely time-consuming. And so, as a result, this ends up impacting our patient's quality of care, as well as the physician has an additional administrative burden, which takes away from their opportunity to take care of the patient in front of them. So, looking at some survey studies, in 2021, the AMA actually did a survey with 1,000 practicing physicians, and they've got some very interesting numbers that I'd like to share with you. So first, from the patient impact. Patients whose treatment required a PA, 93% had delayed access to necessary care a majority of the time. And as we all know what happens when patients can't get the care that they need. They end up in the emergency room, and that ends up costing more dollars and more time and more stress for the patient, as well as, in this case, the insurance company. And so for physicians who are waiting for these prior authorizations to get approved, these patients who are waiting for this treatment, a lot of them, 80% of the time, actually end up abandoning the treatment altogether. They're like, you know what, forget it. The insurance said no. I don't want to do this anymore. And when that does happen, or if it doesn't happen, a lot of times physicians have noticed that these PAs do impact our clinical outcomes. And so a sobering result that we saw from this study is that 91% of the time, these clinical outcomes are impacted by these prior authorizations. And for some patients, in 34% of cases, this delay in care might cause death, it might cause hospitalization, injury, or other life-threatening events. This is pretty significant. Now, for the physicians and the providers that I work with, what does this mean for our offices? Well, I can tell you 40% of physician staff, we have people who just work exclusively on a prior authorization. Practices report that they complete 41 PAs per physician per week. I spent 90 minutes in the clinic today before coming here. I already had 3 prior authorizations on my desk this morning. So such disruptions lead to physician burnout, they add to the administrative burden, and they take away, again, from the patient who is in front of you. Now, these survey numbers are numbers, and I recognize that. And I could probably bore you for hours with multiple stories about patients who have been impacted from prior authorization. But one story I did want to share with you was a girl that I've been seeing. She's in her early 30s. We've been seeing each other since 2017, and she started having really terrible back pain. She was in her late 20s. So started the process, got her started on some conservative treatment, got an x-ray, told her to go to physical therapy. Those are the things I have to do to show that we're doing all these good things and to help with her pain. And she did 8 weeks of physical therapy, and she still didn't have any relief. So I put her in for an MRI, which did get approved, thankfully, and it showed degenerative disc disease with a disc bulge on L5 that was pushing on her nerve. So I sent her to the spine surgeons who said, okay, well, let's try pain management first. Let's try an epidural in your back and see if that helps. So she got about 3 or 4 of those. It helped calm the pain down some. She's been able to manage it since then. And then in 2021, one morning she ends up waking up and she can't get out of bed. And so she ends up in the hospital for about 3 days with this intractable back pain and this difficulty with her mobility. She ends up coming out of the hospital and she's looking at me scared, like, what's going to happen? Is this going to happen again? Like, I can't go to work like this. What do I do? Ended up getting her a second opinion. We tried some other treatments, got it back to another manageable spot. Awesome. She comes back to see me May of this year. She's like, Dr. Taylor, this is getting bad again. Like, the pain is to the point that it was last year when I went to the hospital. Thankfully, she works from home, so she can adjust her position. She's sitting, she's standing. She might lay down in the middle of the day and then get her work done later. I said, we got to get an MRI. I just send her to the spine surgeon again. They're like, we got to get an MRI. I had put the order in already. It was the middle of May. I get a message back at the end of the month. This has been denied. Okay, here's the phone number. Call the phone number. They're like, meh, you actually called the wrong number. Here's the correct number. Call that number. It's an automated service. I don't have a human to talk to. Find the name of the company that wants the information. Find that off of Dr. Google. Call them. Tell them what's going on. They're like, well, she hasn't completed 6 weeks of physical therapy. We're going to deny that. So I then spend my time writing a letter outlining all the details of her treatment. I submitted this on June 8th. 6 weeks later, at the end of July, I finally get the thing approved. It's now, this disc bulge is now pushing more on her nerve, so now she's having burning nerve pain that is going all the way down her leg, and that's impacted her quality of life all summer. I still don't know what the next step is going to be because we've had so many delays in her care. I can tell you the last time I saw her, she was walking with a walker because of how much pain she's in and how much this delay has impacted her care. So, unfortunately, I have to tell you the overuse and misuse of prior authorizations is across the board. It's commercial insurance, it's Medicare, it's Medicaid, it's all of them. In particular, they've noticed with Medicare Advantage plans that a lot of times services get denied when if the patient had regular Medicare, it probably would have been approved. This has gotten to the point that the House, the United States Congress, I should say, has actually recognized this, and they unanimously passed House Bill 3173, Improving Seniors' Timely Access to Care Act, with 326 bipartisan sponsors. I don't have to tell you what an astounding feat that is in Washington, D.C. We're hoping that the Senate will pick up this bill soon and vote on it as well. Now, on the state level, we've seen a lot of possible reforms also happening. And one state in particular that has been very proactive is actually Texas. And the Texas bill, which got approved in 2021, allows that physicians who have approvals on a high percentage, greater than 90% on these prior authorizations, could have an exemption status for whenever the next time is that they order that same procedure or medication. So Kentucky physicians did respond favorably to this bill, and Representative Moser was kind enough to file House Bill 343 last year during the session. And this largely mirrors the Texas bill. And so this would require any state-regulated health benefit plan as well as Medicaid-managed organizations to establish an automatic approval process or exemption for prior authorization. So if the physician meets certain thresholds, like for example, every time I order that MRI of the lumbar spine, the insurance company can see, hey, you've already done the conservative treatment. You've done the 6 to 8 weeks of physical therapy. You got that x-ray. Okay, we know 90% of cases, you're doing all the things that we want. So we will approve this procedure for you. This would dramatically improve quality of care for the patient and the burden that the physician and the physician offices have in terms of getting this care for the patients themselves. So as a result of this is a priority for the KMA in the upcoming legislative session. And I know some of the concerns against this type of legislation would be in regards to cost as well as fraud. First off, in regards to cost. Insurance carriers say by making this change, this will be more expensive. I actually have data to say it would be opposite. So researchers estimate wasteful spending in healthcare, including administrative costs like prior authorization, cost $245 billion a year. Per person, just to make it more manageable, that's $2,497 per person per year. Someone like me filling out these prior authorizations, that cost to me is $10.92 or $14 each for every single prior authorization that I do. And keep in mind, we're doing about 41 of those a week. So, and that does not take into account what my patients are going through. I've already told you about my patient personally who spent all summer with this diminished quality of life, her suffering, her missing work, her being unable to maybe even do those vacations and trips and all those cool things that we all want to get back into. The second concern that I know we'll address is fraud. Well, with this setup, insurers would have the ability to review every single patient or prescriber's exemption status every 6 months. If they see that the physician is no longer meeting that 90% requirement, they no longer have that exemption for that particular procedure. Additionally, if the insurer notes that the physician is gaming the system, if you will, that there's not a medical necessity or it's not an appropriate order of a procedure, they can also revoke that exemption status. So it would be a checks and balance type system. So I do want to conclude with some of my remarks. The KMA has approached the insurers and they have come to the table and we've had discussions about this and how important it is. And to their credit, the insurers have been willing to discuss the issue, ask questions, and express concerns. While we haven't really had any breakthroughs just yet, we've at least been able to come to the table and have a conversation. And like we've mentioned, Representative Moser filed House Bill 343 last year. We're hoping to file something similar this year in that vein to help address prior authorization. I hope you will have a chance to read it and have a chance to reach out to us and help ask any questions. And I do challenge all of you to contact physicians and providers in your districts. If you ask them, what do you think of prior authorizations? I have no doubt you're gonna hear an earful. So thank you for your time today. Thank you, Chair Moser.
Of course. Thank you so much. That was a wonderful presentation, Dr. Taylor, and I can feel your compassion for your patients. And I know that this is a recurrent theme throughout Kentucky. So many providers are just trying to get the care that their patients need in a timely manner. And this, while it may help contain costs for insurers, I think in the short term, in the long run, it really does not. It has the opposite effect. It delays care for patients. It increases the administrative burden for not only the healthcare provider, but also for the insurance companies. The administrative burden is huge. The delay in care, I think you've outlined it all very well, but it also drives up the overall cost of health care. And so I think that this is another measure that we can take a look at, and we are working closely with our insurance providers to come to some sort of reconciliation about how to best do this. And again, trying to put some common sense policies in place that improve healthcare and remove another layer of bureaucracy. So, Corey, I know that you're at the table here. Would you like to introduce yourself for the record and add anything?
Just for the record, Corey Meadows, Deputy Executive Vice President and Director of Advocacy for the Kentucky Medical Association. And I have nothing to add. I think Dr. Taylor covered it very, very well. Thank you.
Okay, thank you so much. We do have a couple of questions. Dr. Alvarado?
Yeah, thank you for being here. Dr. Taylor, those of you who don't know, she's the new KMA president, so happy for you to be here. Welcome to the committee. First time kind of presenting here. I know you've watched a lot of our meetings in the past. This is crucial. It's important. We talk about trying to find savings, and we found savings in our PBM systems. We just had a hearing last month. We'll have a little bit of carryover for the next meeting as well. People that didn't have a chance to testify, on the order of about $480 million in Medicaid alone per year. So about $300 per member in savings that we've gotten. And that's money that patients don't see. The state just got because we made some reform and some changes. That's 36% of our insurance burden in the state. 64% are getting it some other way. So if we want to find savings, there's an opportunity to find savings in healthcare. PBM system is broken. We need to fix it, and that needs to come up in this upcoming year as well. But we certainly don't want to, in a time of burnout, people often worry about what's causing burnout for docs. My opinion is the burnout, we blame COVID and all that, and that's fine. We're pretty resilient individuals as physicians, and we're used to getting a lot of stress. We've been trained that way to handle it. But ultimately, I think it comes down to prior authorization issues for most providers. Just I can't do what I need to do for my patients. Someone else is calling the shots on a phone somewhere, and they're looking at a screen. And let's face it, care is very individualized for people. There's not a algorithm. You have back pain, so here's what you need to do, and this person you're taking care of fits into that. Everybody's story is different. We don't trust the physician's judgment anymore in society. Our insurance companies don't trust physician judgment anymore, and it makes it really, really difficult to practice medicine. And so you don't have fun at your job, it leads to burnout. And the amount of hours that go into this. When I had a practice, 2 full-time individuals just doing this. So appreciate you coming here. We may need your help when session starts up again because we'll get resistance on this issue as well. And I think the Texas model will probably be a good one, so all members be prepared. This is coming our way next session. Thank you for being here and appreciate your testimony.
Thank you.
Yes, it is. We have a few more questions. Senator Berg.
Thank you, Madam Chairwoman, and thank you, Dr. Taylor, for being here today to discuss what I consider to be an extremely, extremely important subject, because we are wasting millions of dollars of health care money doing things like prior authorization and requiring patients that need services to wait and wait while your office staff and their office staff fight back and forth for weeks at a time over what they will or will not cover. Yep. It is a game that I understand at its inception had some purpose, because initially 20 years ago, well, we weren't ordering MRIs at the time, but you had a patient come in with back pain and your first thought, well, let's get an imaging study. That's not appropriate. We now know that's not appropriate. Yeah. Unless certain circumstances, you have risk factors, you have a history, you have other things that make it appropriate at that time. So we were wasting healthcare dollars. But I think we are now to the point where we understand well enough what the indications, what the appropriateness criteria are. They're published, so if you don't know them, you can look them up and read them. That we no longer need to spend this money trying to control utilization. What we need to do at this point is open utilization up to patients that need help and keep our doctors from having to fight day and night and tooth and nail to get their patients the studies they need. So thank you. I just want to tell you 100% understand and agree that this not only helps our doctors, it not only helps our constituents, it actually helps the entire delivery of healthcare services to the state. Thank you.
Thank you.
Thank you, Dr. Berg. Representative Fleming.
Thank you, Chairwoman Mosier. I wanted just to come from a number standpoint, and I appreciate your presentation and your example that you went through with your patient. It's quite telling, and I've seen some things going through within my family and so forth. But from a number standpoint, can you provide, or do you know of, and maybe Texas went through this process in terms of applying some type of a cost allocation to each process, so we can get an understanding of exactly how much money we're talking about. The co-chairman Alvarado mentioned over $480 million on the PBM and so forth, which is a very strong number that we need to really pay attention to. But and I know insurers go through a risk management approach, and they've obviously they're beholden to their employees and to their stockholders if they're publicly owned or privately owned and so forth. But to put, as I mentioned, to put some juice behind this and to tell a story, do you have information, or is that information can be obtained from a Kentucky point of view using models from other states, so we can say, hey, this is what it means in order to go through this process, so we can use it for negotiation purposes or whatever?
Right. No, that's a great question, Representative Fleming. I think we are still waiting on some more numbers from Texas. Since this law passed in 2021, it's just now getting implemented over the summertime. So I think with a few more months, we'll be able to better speak to the costs that they've been able to save.
And I would appreciate that. If y'all can, present it formally or informally, but provide it to both chambers, maybe this coming spring, because the numbers would really tell a story. Definitely. And it will really support the story that you just articulated in terms of providing quality care for that individual, as well as keeping your sanity in paperwork. So thank you, Madam Chair.
Thank you. And I think as we move through this process, we'll be able to provide some of that data as we discuss the legislation. So I think with that, we are finished with our agenda today. I would like to announce that the next interim joint committee hearing on health, welfare, and family services will be held November 15th. That is Tuesday instead of Wednesday, and that's at 11 a.m. So there has been a date change and a time change to please take note of. Thank you so much for your presentation. Thank you to everyone who stuck around for the entire meeting. I think we learned a lot about access to care, quality of care, and the cost of care, and these are all issues that we are working to address in this committee. And I just saw Senator Harper Angel walk out, but I did want to express our condolences on the loss of her husband. Very sorry about her loss. And then our good friend, Representative Prunty, lost her dad, and we are with you in prayer and wish you all the best. So, okay, with that, we have no further business, and thank you all, everyone, for sticking around, and we are adjourned.